Okay, welcome everyone to our Northside conference. We're going to go ahead and get started. Again, it's my pleasure to be here today. So I do try to present this lecture once a year. I don't think that I presented it last year. As we continue to deal with the COVID-19 pandemic, we want to make sure that we don't forget about our bread and butter in infectious disease, and diabetic foot infections continue to be a major cause of morbidity and mortality in our country, and one of our most common areas of intervention as infectious diseases specialists. And I always like to begin this talk by acknowledging people who are in the public realm who have had diabetes-related complications. And one of these individuals was the great Ella Fitzgerald. For those of you who are fans of music or jazz, she was asked in 1993 what factors had led to her diabetes-related leg amputations, and she replied, "I like to wear pointy-toed evening shoes." And this outlines, I think, some of the difficulties that we have in our patients to prevent diabetic-related foot complications. And in fact, she's not only alone in being a celebrity with type 2 diabetes. Thomas Edison had type 2 diabetes, the great Tom Hanks, a current actor, as well as all the individuals on here. George Lucas, for those of you who are Star Wars fans, and Billie Jean King, one of the most memorable female sports celebrities and accomplished tennis players, and James Earl Jones, the voice of Darth Vader. So these are all people who confront type 2 diabetes in our society. So I originally created this talk about 20 years ago and have been updating it ever since. So where are we in the so-called roaring 20s? This is 2021. We're in the roaring 20s, if you want to use that term. Well, unfortunately, we're kind of a decade behind in our diabetic foot guidelines because the latest IDSA guidelines were released in 2012, almost 10 years ago. IDSA updated guidelines are promised soon, but with the impact of the COVID-19 pandemic, we can't really be totally sure about this. What's changed, I think, since I updated this talk 2 years ago is a more recent emphasis on the role of pathogenic bacteria in wound breakdown and the inhibition of healing, especially through the production of biofilms. And then in 2019, there was a landmark OVIVA study which gave support to oral antibiotic therapy for the treatment of diabetic foot osteomyelitis in certain cases. But as was the case when I first put this talk together in the late 1990s, the goal should still be to preserve limbs. And that's what we should continue to do as infectious diseases specialists. But we're not alone, because there are actually a plethora of disciplines that are involved in the management of diabetic feet and diabetic foot complications. So even though I've placed the infectious disease specialist very close to the top of with the primary care MD and the endocrinologist in the management of diabetic feet, we know intuitively that podiatrists, pharmacists, home care specialists, general and plastic surgeons, vascular surgeons, radiologists, these are all disciplines that are involved in the care of the diabetic foot. This is a Venn diagram showing the impact of multiple categories of diabetic foot complications, ultimately leading to the subgroup of individuals that experience a foot ulcer or limb loss, and where they intersect. And although individuals affected with diabetes is a small segment of the population, this diagram was from 2013, and the subsegment of individuals with diabetes is actually quite a bit larger now. We realized that although 1.3% of individuals with diabetes experience limb loss, that's actually a very large segment of the American population. The latest data that I found, this is from the National Diabetes Statistics Report from 2020, suggests that about 34.2 million individuals are diabetics in the U.S. population. That's about 1 in 10. And of these individuals, about 1 to 6% annually develop foot ulcers. That's about a quarter of diabetics in their lifetime. And there's a $9 to $13 billion cost on public and private payers. And it's been estimated that unless current trends change, about 1 in 3 U.S. citizens could have diabetes by 2050. Now, what are the costs per diabetic foot ulcer in the USA? Well, Rice and colleagues in this article in Diabetes Care in 2014 looked at more than 32,000 patients with type 1 or type 2 diabetes, and found that the annual incremental healthcare costs amount to up to almost $17,000 per patient in those with a foot ulcer. And there's over $3,200 cost assessed in annual work loss. So diabetic foot ulcers exact a heavy financial toll, not just on the individual patient, but on society as a whole. So we can look at risk factors for foot ulceration and infection by individual risk factor. We know that peripheral motor neuropathy leads to altered foot mechanics. Sensory neuropathy induces a lack of protective sensation. Autonomic neuropathy leads to breakdown of wounds due to deficient sweating and cracking of skin. But we also need to consider things like vascular insufficiency, which can impair wound healing, tissue viability, and the delivery of neutrophils, defensive factors in the ability of wounds to heal. But patient disabilities, maladaptive behaviors, and health system failures also can contribute. This is a diagram related to amputation in olden times, in the 17th and 18th centuries, for example. I just want everybody in the audience to imagine how the trauma and stress that a patient would have had confronting amputation, let's say in Civil War times. Anesthesia was perhaps limited only to taking a swig of alcohol or whiskey. You had orderlies holding the patient down, and one can only imagine how difficult this was in times before we had effective medical treatment. And this led the great 18th century British surgeon and anatomist Sir Astley Paston Cooper to remark, "He is a good surgeon who can amputate, but he is a better surgeon who can save a limb." And I think that we, as infectious diseases specialists should look at this philosophy in our ability to prevent amputation. And why we should prevent amputation, I'll get into more later on in this talk. But despite our efforts to prevent amputations, they're actually much more common than we might otherwise think. In the US, as of 2016, there were 130,000 lower extremity amputations per year. And there's an amputation secondary to diabetes every 30 seconds or less. This amounts to more than 350 Americans per day. And there are higher rates in men and in underserved populations. Amputations are estimated to cost as much as $60,000 per case, and they amount to $2 billion per year in total costs. Now, the morbidity of lower extremity amputations can be profound. It's thought that the 5-year mortality rate for any amputation is between 53 and 100%. So this means that if your patient gets a lower extremity amputation, the chances are great that they will succumb to mortality within 5 years. An AKA can lead to a 5-year mortality rate of 40 to 90%, and a BKA from 40 to 82%. So it doesn't really matter if your patient gets a BKA versus an AKA. The 5-year mortality is profound in both groups. And risk factors for increased mortality include age, renal disease, peripheral vascular disease, and if someone achieves a proximal amputation, the incidence is slightly higher, but still, even in BKAs, the 5-year mortality rate is significant. And we can see this in this graph from the International Best Practice Guidelines from 2013. When you look at the 5-year mortality rate of diabetic complications, whether it be a neuropathic ulcer, amputation, ischemic diabetic foot ulcer, or peripheral arterial disease, there's not that much of a difference between those entities and lung cancer or pancreatic cancer. So there is a significant degree of mortality with diabetic foot-related complications. Now, this is a complicated slide, but to simplify it a little bit, to kind of make it a little easier to understand, there's really a limited number of factors that can progress to amputation in diabetic foot patients, diabetic foot ulcer patients. As I've said earlier, it's really the combination of neuropathies, peripheral arterial disease, and infection, which ultimately leads to amputation in these patients. As I said before, sensory neuropathy leads to a reduction in protective sensation, which can increase foot pressure and minor trauma and decrease minor trauma recognition, leading to the formation of a callus, which forms a pre-ulcer and ultimately ulceration. Motor neuropathy can lead to muscle atrophy. This can alter the biomechanics of the foot and lead to the formation of a diabetic foot ulcer. Autonomic neuropathy reduces sweating and leads to dry skin, which can cause fissures and lead to an ulcer. All of these ultimately lead into the effects that infection can produce on the foot. Peripheral arterial disease, also by leading to ischemia, can form an ulcer, but it can also impair healing, because if you don't have a good blood supply leading to the foot, you can reduce the ability of protective immune factors and antibiotics to get to the site of the infection. So really, it's the combination of neuropathies, peripheral arterial disease, and infection which leads to amputation. A common area of diabetic foot formation is the plantar surface of the foot, and so what happens is when you have diabetic neuropathy, this leads to the development of contractures in the distal foot, which can thrust the MTP joints down and the interphalangeal joints up. This leads to the production of a hammer toe. When this occurs, there is improper weight balance in the foot. This leads to breakdown at the base of underneath the MTP joints, leading to an ulcer. And once an ulcer occurs, infection often follows. And when an infection follows, the underlying bony surfaces are inevitably involved, and that ultimately leads to amputation. More about amputation. The effects of amputation on the quality of life can be devastating. Many individuals regard amputation as an occurrence that they really simply cannot deal with. And that's why we oftentimes get such resistance to amputation in our patients that we see. Amputation has the potential for long-term physiological and psychosocial effects. It can limit activities of daily living, impair patients' ability to move around and do all the things they did before. It can lead to depression, the loss of social contacts, early retirement, decreased income, and a lot of other complications. So amputation has a devastating effect on our patients when it occurs. Now, there are several different wound classification systems in individuals with diabetic foot ulcers. The Wagner system is perhaps the most established, but there are several others, including the University of Texas classification, PEDIS, and SINBAD. And the Wagner grading system has a series of grades from 0 to 5, and you can see how they are categorized here. A Wagner grade 0 example would involve, a Wagner grade 1 would involve minor breakdown to the foot with preservation of the second layer of tissue and erosion of the epidermis. A Wagner grade 2 is a more involved ulceration, and a Wagner grade 3 involves the formation of an eschar and significantly more complications. The University of Texas classification system is an update to the Wagner classification system, which eliminates grades 4 to 5 and adds stages A to D to the grades. And this is the first diabetic ulcer assessment tool to receive validation. The PEDIS classification system is kind of more of an acronym and uses classifications from 1 to 4 in the manner noted here, whereas 1 is an uninfected ulcer to an infected ulcer with local signs. 2 involves more of a minor infection involving only the skin and subcutaneous tissue. And the succession of 3 and 4, as you can see here, involves more deeper structures and the presence of more of a systemic response as seen in the criteria listed. I want to talk a little bit about Charcot Arthropathy, because oftentimes this can really make our assessment of a diabetic foot more difficult. Charcot changes can be closely mimic diabetic foot infection. They can alter the biomechanics of the foot, so we can see here in the lower left. And they can also produce radiographic and physical changes that can mimic osteomyelitis. So the presence of a Charcot foot oftentimes can make our job difficult. Is this simply Charcot changes, or are these changes that we see radiographically or physically, are they more infectious in etiology? And in saying this doesn't mean that patients with Charcot changes cannot have diabetic foot related infectious complications, but many patients with Charcot changes, they don't really require antibiotics. What they really need is offloading of their foot and further assessment to exclude infection. Now, what about the assessment of the diabetic foot? Well, really, the diabetic foot exam is an essential component that all of our primary care colleagues should be very familiar with, as well as us when we assess these patients. A simple diabetic foot exam is one of the most important means of prevention. It should be done annually, at least, if possible. It can be done in as little as 3 minutes. So this is the 3-minute diabetic foot exam, and really it involves what to ask, what to look for, and what to teach. So what to ask is listed here. Does a patient have a history of previous diabetic foot ulcer, prior vascular complications, a foot wound requiring more than 3 weeks to heal, the presence of tobacco or nicotine use, and does the patient have a previous diagnosis of diabetes, or maybe an unknown diagnosis of diabetes? And does the patient have any of these symptoms, burning or tingling in the legs or feet, leg or foot pain, loss of lower extremity sensation? And has the patient establish regular podiatric care. These are the things you want to look for. You want to look for discolored toenails, signs of fungus infection, which can correlate with diabetic foot complications, open wounds or fissures. You want to assess the neurologic exam. Does the patient have responsiveness to the Semmes-Weinstein test or the Ipswich touch test? Does the patient have a full range of motion of the joints? Does the patient have vascular changes that are suspicious for vasculopathy? And what to teach? You want to provide recommendations for daily foot care, encourage patients to visually examine their feet daily. You want them to keep their feet dry by regular foot care, changing their shoes and socks, drying their feet after baths or exercise. You want them to report any new findings to a healthcare professional. You also want to educate the patient on the risks of walking barefoot, on the importance of appropriate foot care, and on overall health risk management, whether that be smoking cessation or appropriate glycemic control. I talked about screening for neuropathy. For many decades, the importance of diabetic assessment has been emphasized with what's known as the Semmes-Weinstein monofilament test. Those of you who have a monofilament can do this exam. It involves applying the monofilament line to several areas of the foot and applying pressure. The inability to feel this pressure is strongly associated with diabetic foot complications. In more recent years, what's called the Ipswich touch test has become better validated. For those of us who don't have a monofilament line to do the testing, all of us have our fingers and the ability to examine a patient's ability to feel our finger on the first, third, and fifth toes. The ability to feel depression or pressure with the finger in a head-to-head trial, both methods were comparable in detecting loss of protective sensation. So you can do the Ipswich touch test if you don't have a monofilament line. Apply your finger to the tip of the first, third, and fifth toes. Ask the patient to indicate when they feel something. If they can feel something, that is associated with the ability to feel for possible causes of factors that can induce an ulcer. But if you don't have that feeling, that is comparable to the Semmes-Weinstein monofilament test regarding the loss of protective sensation. And here in the VA, we do a better job than in other facets of medical care, such as private insurance or Medicaid related practice encounters. But still, when you look at the average, about 2/3 of patients are not getting annual diabetic foot exams, and these are so important to prevent diabetic complications. Now, there's no doubt about the importance of this and the significance of vascular disease to the epidemiology of diabetic foot complications. There's a significantly increased risk of peripheral vascular disease in diabetic patients. This is a patient, I think you can argue, who has vascular complications contributing to their diabetic foot situation. The risks of peripheral vascular disease in diabetic patients is profound. This is a study which showed an odds ratio of more than 2.5. The risk is exceeded only by smoking. There's also an increased risk of death in patients with diabetes and peripheral vascular disease. Now, risk factors for diabetic foot complications are listed here. The ones in red are things we can't really do anything about. They're not really reversible. We can't really reverse our genetic predisposition or our age or the duration which patients have diabetes. But all of these other risk factors are reversible, and among the most significant is smoking. Encouraging smoking cessation in our patients is, I think, something that all of us need to do, and smoking is really among the worst of any listed here. This is a patient I took a picture of, back when I was in private practice with diabetic foot-related disease. This patient had already had another amputation, and this was their remaining limb. And you can see some of the well-known signs of peripheral vascular disease, in that the skin of their foot is very shiny and atrophic. They have onychomycosis, which tends to it finds a very favorable environment in patients with poor diabetic foot control. The ulcers that you see were not due to diabetes, but this patient was also a smoker and dropped a lit cigarette on their foot, encountered a burn, and then developed an ulcer. So consider all these symptoms and signs as being related to peripheral vascular disease. Cold feet, this is a sign of common sign of diabetic ischemic vascular disease. Intermittent claudication and nocturnal and rest pain when it progresses from intermittent claudication. This is guaranteed to lead to the need for revascularization if possible. How do we evaluate the diabetic foot? What are our diagnostic evaluation tools? Well, NIVS is something that we use in our practice very commonly. The non-invasive vascular studies. Segmental pressures can also be helpful in assessment, including formal testing for ABIs, arteriobrachial indices. And an ABI of less than 0.9 is diagnostic for peripheral arterial disease with a compatible history. We also want to take advantage of the measurement of toe pressures. Toe pressures that are under 30 millimeters of mercury are so strongly associated with ischemic complications. For many practitioners, contrast arteriography is still the gold standard, but other modalities such as MRA or multi-detector CT or transcutaneous O2 measurement are also useful modalities. Now, how do we measure the arteriobrachial indices? In this, we measure the higher of the two right ankle pressures over the higher of the two arm pressures on the left and the right. And we use this basis to calculate an ABI in the manner shown here, measuring the dorsalis pedis pressures with the detector, and then we calculate the ABI on that basis. So a normal ABI is between 0.91 and 1.3. Mild obstruction is usually between 0.71 and 0.9. Moderate obstruction between 0.41 and 0.70. And severe obstruction is defined as less than 0.4 to 0.5. When patients have an ABI that is over 1.3, this is usually to poorly compressible vessels in patients who have significant calcification of their vascular arteries. And these individuals will need other assessment in order to assess the significance of their peripheral arterial disease. Now, not all patients with peripheral vascular disease and diabetes need to progress to surgical intervention. Smoking cessation in our patients can be very significant. The recommendation of a graded exercise program, diabetic foot care, intensification of that approach, treating any hyperlipidemia, optimizing their diabetic control, and considering antithrombotic therapy. And periodic vascular lab reassessment is important as well. What are the definite indications for revascularization? Well, if a patient has intractable or disabling nocturnal or rest pain, the presence of a non-healing ulcer, especially an ischemic ulcer, or the presence of gangrene, these are indications for revascularization. Now, there's a subsegment of the practice of management of the diabetic foot that involves biomechanics. So, what are biomechanics? These are the specific factors in a diabetic foot that produce or cause patients to have physical forces that can lead to ulceration. So what are some factors that are some biomechanical factors that can lead to foot ulceration? Well, if the patient has poorly fitting footwear, if they don't pay attention to what footwear that they're wearing or the forces that impacts on their foot, especially on the dorsum of the foot, that can lead to ulceration. Also, structural ulcerations, such as Charcot changes, hammer toes, or even prior amputation, this can induce factors on the foot that can lead to ulceration. Many patients lose strength in their foot because of motor neuropathy. They can have existing wounds that they favor or they avoid, which can impact other areas of the foot. And also, if they have an abnormal posture or gait, that can also biomechanically lead to ulceration. So if you think about it, a lot of the patients that we see with diabetic foot ulcers, they're really on the plantar surface, either under the first or second MTP joint, or especially under the third. And so these are areas where abnormal pressure lead to tissue breakdown and ultimately the formation of an ulcer, infection, and underlying osteomyelitis. Now, once infection occurs, it's the single most common factor leading to amputation. And we know that the response to infection is altered in the diabetic patient because of hyperglycemia, vascular factors, and other diabetes-related factors. And once infection occurs, superficial cultures they can be less reliable. And also, we have an obligation to define the extent of the infection. Is this just a superficial infection? Is there deeper involvement, either the deeper soft tissue structures or underlying bone? Now, more recently, there's a recognition that really there's individual factors other than infection that are related to the infectious process that can lead to the formation of a diabetic foot wound and can also impair wound healing. So in diabetic foot ulcers, tissue repair becomes dysregulated. Injury leads to widespread tissue necrosis, the proliferation of a wound callus, and excessive inflammation. And this can lead to what is known as the formation of a metalloproteinase matrix, or an MMP, rich proteolytic wound bed, which impedes granulation, delays vascularization, and results in a hypoxic local environment. Open wounds become contaminated with microorganisms, leading to colonization. This constellation of different bacteria directly alter the wound environment and negatively affect healing. This leads to the establishment of pathogenic biofilms, which can contribute to chronic and persistent infections. Now, biofilms are difficult to get rid of. We know this intuitively for where biofilms occur elsewhere, such as on our teeth. That's an easy concept for all of us to understand, that when biofilms occur in our teeth, they really require physical disruption, by our toothbrush, by the act of brushing, to go away. Well, where biofilms occur on diabetic wounds, they are very difficult to disrupt, and they respond really best to physical debridement, and much less reliably to topical agents or even systemic antibiotics. Now, it's been long known that certain pathogens are associated with various clinical foot infection syndromes, and that has formed the basis for why we treat with certain combinations of antibiotics. I think all of us can recognize that when we have a patient with an open skin wound, the common bacteria that colonize the skin, whether it be streptococcal organisms or Staphylococcus aureus, are typical pathogens that we culture from wounds. If we have somebody who's antibiotic naive, a lot of times agents intended to address these topical organisms are the ones we typically reach for. If we have somebody with a more chronic ulcer, somebody who's antibiotic experienced, Staph aureus, beta hemolytic streptococcus, or Enterobacteriaceae are common targets that we would target with our antibiotic therapy. Somebody with a macerated wound because of soaking, we think about Pseudomonas aeruginosa. Patients with long duration wounds, they may require more broad spectrum antibiotic therapy because their wounds have been colonized over a long period of time. And somebody with extensive necrosis and gangrene, somebody with a malodorous foot, I think we can recognize the greater importance of anaerobic bacteria, non-fermentative gram-negative rods, and enterococci. What are some indications of infection in the diabetic foot? Because I didn't get that. Because we know that that diabetic foot patients lose a lot of their protective sensation sometimes, and they have autonomic neuropathy. A lot of times, the presence of infection can be more difficult to detect in a patient's foot. And there we may need to go by clues such as drainage, the presence of erythema, a foul odor, tissue necrosis or gangrene, systemic leukocytosis, or elevated inflammatory markers. Now, once osteomyelitis occurs, it frequently progresses to amputation. And most patients develop osteomyelitis not through systemic spread of infection, but through a contiguous focus. And we want to take into consideration the location, what the patient's vascular status is, the extent of soft tissue and bony destruction, and the presence of systemic illness, as well as what the patient's preference is. Do they want antibiotic treatment alone, or are they okay with local debridement, or are they willing or totally resistant to consider surgical resection or amputation? How do we diagnose diabetic foot osteomyelitis? Well, in Grayson's landmark New England Journal study from 1995, it was validated that the presence of exposed bone in a diabetic foot infection strongly correlates with the presence of underlying osteomyelitis. But if we don't have an exposed bone, then oftentimes we will go to other modalities such as plain X-rays, MRI, nuclear scans, or some other modalities as well, including tagged WBC scans, three-phase bone scans, and so forth. Now, this is a paper from Din and colleagues in CID in 2008, looking at the diagnostic accuracy of physical examination and imaging tests for osteomyelitis. And we can see that, again, exposed bone, the ability to probe, put a sterile metal probe to underlying bone is very specific and incredibly sensitive and adequately sensitive for diagnosing osteomyelitis. Plain radiographs are sensitive as well, but not very specific. MRIs, I think of all of these modalities, have the highest sensitivity and probably as good sensitivity only to the presence of exposed bone as any other modality listed here. So this is why we commonly use MRI over leukocyte scans or plain radiographs as probably our most helpful diagnostic imaging modality to diagnose underlying osteomyelitis in a foot ulcer. Now, what are some general principles of treatment once osteomyelitis is diagnosed? Well, surgical removal of involved bone is an essential component. And I want to differentiate between debridement, which is the sort of piecemeal surgical removal of devitalized tissue, from resection, which is usually involves a surgical margin and with the intent of being curative. So debridement is a surgical modality, resection is another. Sometimes the lines between debridement and resection can be very grayed, and we as infectious disease practitioners are called upon to make that determination. Is this a curative resection, or does this patient need antibiotic therapy because of the presence of residual osteomyelitis? Patients who have impaired circulation may need restoration of their circulation in order to give them the ability to adequately heal a wound and also to carry our antibiotics to the site of the infection. In antimicrobial therapy, I think there's a recognition that at least 4 to 6 weeks is necessary. More recently, it's become better understood that there may be some cases where oral antibiotic therapy alone may be adequate, as opposed to those patients who need 6 weeks of IV therapy. And antimicrobial selection most often is based upon deep cultures, bone biopsies, and so forth. Now, what about debridement? Because there are several different types of debridement that we should be aware of. I think most of us would agree that sharp surgical debridement is the gold standard for diabetic foot wounds. However, there's a lot of different types of mechanical debridement, and this can include wet to dry dressings, irrigation or lavage, biotherapy, and even what's known as larval therapy, which is the use of maggots. Yes, maggots are sometimes used to larvally debride wounds. It's a modality that maybe has fallen by the wayside, but there's still some devotees to larval therapy, believe it or not. Enzymatic debridement uses enzymatic preparations like collagenase, for example, and autolytic debridement uses sort of next generation wound preparations which remove slough and allow wound to be cleansed correspondingly. So essentials of management for antibiotics. Well, we want to include coverage for MRSA and Pseudomonas aeruginosa. Our specific therapy should be based upon invasive cultures and biopsies, and we have to coordinate our management. In other words, we have to give antibiotics in conjunction with any surgical debridement that is provided. A more recent controversy is whether or not it's necessary to include coverage for other polymicrobial organisms within the wound bed, such as those that contribute to the formation of biofilms. And I can't really give you an answer about whether that's necessary nowadays. I tend to be a little bit more of a traditionalist, including coverage for those organisms that are thought to be the most relevant within a wound, which we can culture through our invasive biopsy procedures. But just be aware that this is a controversy, and some providers may argue for broader therapy on this basis. So we all know our gram-negative agents that we commonly reach to for diabetic foot infections, and those include those listed here. Gram-positive therapy directed against MRSA and gram-positives, I've listed here. I don't need to go over these in too much detail. I did want to talk about however, about the OVIVA trial, which was published in the New England Journal in 2019, because this is changing our thought process about the management of antibiotic therapy in some patients with osteomyelitis. So the OVIVA trial was a multi-center randomized open-label trial in the UK, which involved the assessment of the non-inferiority of oral antibiotics compared with IV antibiotics in bone and joint infections, in which diabetic foot osteomyelitis was also a subcategory. This was from 28 UK centers, and the participants were randomly assigned to receive IV or PO antibiotic therapy for 6 weeks, plus or minus debridement, and follow-up was for 1 year. Now, in this situation, in this study rather, a accredited ID specialist made treatment decisions, and other associated treatment modalities such as antibiotic impregnated cement and even the use of rifampin were permitted. And the primary outcome was the rate of treatment failure. So in other words, which modality, either oral antibiotic therapy, all oral antibiotic therapy, or IV antibiotic therapy, had treatment of failure occur. So this is from the study, and you can see that the primary outcome of definite treatment failure satisfied the non-inferiority margin. So the non-inferiority margin, these groups fell within that margin in the intent to treat group, the modified intention to treat group, the per protocol group, and the worst case sensitivity groups. So in other words, quinolones and combo therapy, in other words, I should say, there really was no difference in failure between oral groups and IV groups in all of these in these study groups. The most frequent IV antibiotics were glycopeptides and cephalosporins. Quinolones in combination therapy with ciproclinda or ciprodoxy were the most common PO agents prescribed, and rifampin was more commonly given in PO groups. So having to go through this trial very briefly in terms of this overall talk, the conclusions of the OVIVA trial, if I can present them to the group, were that if oral regimens are appropriately selected, they can be as effective, more convenient, and less costly than IV regimens. There was less potential for adverse events such as those due to central IV catheters in oral regimens. Now, not all cases of osteomyelitis mandated the use of IV antibiotics in this trial. There were some cases that oral therapy was acceptable, and I think what we need to take away from the OVIVA trial is some of our less complicated cases where the organisms isolated are much less in doubt. They're not controversial. If these are pure Staph aureus infections, for example, or strep infections, we can use oral therapy in these cases with confidence. It still doesn't mean that there won't be more complicated cases, maybe patients who have vascular insufficiency, who have more complex culture results, where we want to use IV therapy. But there are some cases now where we can consider oral therapy as a reasonable alternative. Now, when we do consider IV antibiotic therapy or oral therapy, either IV antibiotic therapy alone or oral therapy as maybe a modality to go to after an initial case of IV therapy, what are the treatment durations that we need to consider? So if somebody has a mild soft tissue infection only, 1 to 2 weeks is okay. It may extend up to 4 weeks if it's slow to resolve. Somebody with a more severe soft tissue infection, 2 to 4 weeks. Somebody with osteomyelitis, actually, who has a curative resection, where there's thought to be no residual bony infection and clean surgical margins, oftentimes they only need 2 to 5 days. Somebody with a residual soft tissue infection may need 1 to 3 weeks. Somebody with a residual bony infection where the surgical margins are not clean obviously may need 4 to 6 weeks. A patient who is not a surgical candidate, who has residual dead bone or chronic osteomyelitis, those patients are going to need maybe an initial course of IV therapy, but then they may need chronic suppressive therapy, particularly if they have no other surgical options, and the only option that may be left on the table is amputation, either a BK or AKA. So those are some of the patients that we give chronic suppressive therapy for. Now, getting diabetic wounds to heal, I'm going to try to finish this up in the next 5 minutes. That's kind of the next step. How do we heal a diabetic wound in a patient in whom we've diagnosed with diabetic osteomyelitis? They may have completed their treatment, and we want to cure their soft tissue process. Well, the treatment of wounds have been going on for millennium, and these are some ancient cures that some of which we still may stick to, like zinc oxide, but others like dung, mud, and cow's urine, we want to definitely avoid. So the initial principles of diabetic ulcer management I've listed here. So we want to, in recent years, it's been acknowledged that we want to debride and manage biofilms aggressively with topical strategies that kill residual biofilm bacteria. Then the treatments shift to less aggressive topical therapies to reduce bacterial burden. When the wound bed is ready, we shift to advanced wound treatments that stimulate healing. So, in other words, aggressively debride the biofilms, and that may require surgical debridement or other strategies. Then shift to less aggressive topical therapies that reduce the bacterial burden, and then shift to strategies that kind of rev up soft tissue growth, the formation of granulation tissue, and that epithelial layer that completes the healing process. We can think about wound dressings in terms of conventional, sort of traditional wound dressings, and that includes gauze, packing strips, advanced wound dressings like silver cell that we see in a lot of our patients, hydrogels, tegaderm films, and foams. And then this is from a recent publication, The Management of Diabetic Foot Infections by the American Diabetic Association. It sort of looks at those next generation products that are anti-biofilm. And those can include things like Plurogel, it's a surfactant gel, nanoparticle dressings, zinc oxide, laser therapy, which I'll get more into in just a second, iodosorb. These are products that are recognized as supporting anti-biofilm activity. There's a lot of reasons why wounds don't heal. Was our therapy, our antibiotic therapy, targeted enough? Are there vascular issues? Have we optimized our wound management regimen? These are all reasons why wounds don't heal. So these are some adjunctive therapies that I found that are in more recognized in sort of in the 20s as offering some adjunctive benefit. Negative pressure wound therapy, the wound vac, we're all accustomed to. It's a modality we see used very often in our patients in our own hospital. Some others include newer generation surfactant wound gels, low-level laser therapy, using the patient's own blood components to form a healing wound patch, ultrasound therapy, topical wound oxygen therapy, and others listed here. So the wound vac, we know, falls under the category of negative pressure wound therapy, and this is a modality that basically applies negative pressure or suction to a wound bed in order to debride the wound, remove excessive moisture, and allow a wound environment to encourage healing. So this is a modality that we see commonly used in our patients. And sort of next generation topical wound gels, this is one that I found recommended in the recent ADA statement called Plurigel. It uses a micelle matrix technology that produces a ideal surfactant that removes biofilms and is supposed to form a receptive wound healing environment. Low-level laser therapy, yes. Those of us who believe that lasers, can they heal everything? Well, lasers are thought to accelerate wound healing by promoting cellular proliferation and decreasing inflammatory response, increasing collagen synthesis. It's also mildly ablative to the tissue. It performs a debridement function, and it is bactericidal. So this is a modality that I'm seeing being used. The leucopatch is a multi-layer patch made with the patient's own leukocytes, platelets, and fibrin that is applied to the wound and enhances healing of patients with hard-to-treat diabetic foot ulcers. So you make up this matrix based upon the patient's own blood components, and it's thought to induce a healing of diabetic foot ulcers. Ultrasound therapy, believe it or not, is thought to play a role in disrupting biofilms through sonic action. So yes, even ultrasound can be used to heal a diabetic foot wound. This is a recent modality that I found really interesting. For many decades, hyperbaric oxygen has been advocated for these patients, but topical wound oxygen therapy, cyclical topical wound oxygen therapy, actually uses a plastic boot applied over the patient's foot to apply normal, not hyperbaric, but normal oxygen therapy to a diabetic foot in order to increase local oxygen pressure to allow a wound to heal. So hyperbaric oxygen, it's kind of a misperception that hyperbaric oxygen actually gets into a wound and causes and increases oxygen tension in the tissues. But really, the benefit of hyperbaric oxygen is systemic. The lungs inhale a higher pressure of oxygen, and it gets in systemically. So if you have impaired vascular status, even hyperbaric oxygen is less likely to get to the wound. The thought is whether topical oxygen therapy can actually penetrate the wound. And there's actually an evidence basis for this. I've placed some recent publications at the bottom of this slide for those of you to look up. And this is not a modality that we use here in our facility, but there may be some further evidence basis for it in outpatients. So be aware of this cyclical topical wound oxygen therapy as having an evidence basis for use. So I'm going to close the talk just by talking about post-treatment considerations. These are things that we can all advocate for our patients to prevent ulceration, from gait modification to daily foot inspection to the use of therapeutic shoes, avoiding hot water, drying. Patients should dry their feet in between foot washings, lubricate their feet daily, avoid sharp instruments, be careful with the cutting of their nails, avoiding temperature extremes, wearing optimal footwear, and so forth. Rounded shoes rather than pointy shoes. wearing white shoes, which make their feet easier to look at, and so forth. So I'm going to close with this quote from Ella Fitzgerald, bringing it around 360 as words of inspiration. She liked to say, "It isn't where you came from, honey, it's where you're going that counts." So let's all look forward rather than backward in our management of diabetic foot infections. And this is my summary slide. So you all have been a patient audience. Are there any questions about diabetic foot management from the group? And I will open it up to questions.